for this session. First, we'll call upon Dr. Laila S. Mohan. Dr. Laila needs no introduction. She is working in Comtrust Eye Hospital. Everybody knows about her, so I'm not going into much detail. Over to Dr. Laila.
Thank you, madam, for that sweet introduction. Can you? First of all, let me thank Dr. Lakshmi for giving me this opportunity. This particular topic is something which I love. So, I'm going to talk about ocular torticollis, approach to ocular torticollis. എന്താ വരാത്ത എവിടെയാ I can see it on my laptop. Yeah. So, approach to ocular causes of torticollis. Ocular torticollis or torticollis means twisted neck is the commonest of the torticollis, and others being orthopedic, which can be either muscular, ligamentous or osseous, and neurologic. It may develop early in infancy or may be acquired, and ocular torticollis may be to optimize vision as in nystagmus, monocular blindness, ptosis, refractive error, hemianopia, or to maintain binocularity as in concomitant strabismus. So, ocular torticollis in early childhood can lead to facial asymmetry as well and may progress if not corrected early. So, how do we come to a conclusion whether it is ocular or not? So, proper history, duration, constancy, laterality, family albums may show whether it has been there since infancy. Examination to see whether visual acuity is equal in both eyes, ptosis is there, ocular alignment, PBCT to measure the deviation, whether it is comitant or not, versions, and sometimes Park's 3-step test whenever necessary, and some of the special tests like force duction test to rule out a restrictive component, and force generation test to plan surgery, and measure face turn and head tilt also. Facial morphometry, that is the asymmetry, can also be measured if we want, which will give you an idea whether it has improved after surgery. And when there is nystagmus, look for a null gaze. So, to maintain binocularity, it may be either a paralytic problem, restrictive problem, or a pattern strabismus. I hope you can see this abnormal posture may be either a face turn. This is right face, left face turn and right face turn, head tilted to the left side and right side, and chin up posture with left face turn and chin up posture. So, these are the 3 components of head posture: face turn, head tilt, and chin position up or down. So, patching 1 I will show whether he improves after patching. You can see in this girl, she was sitting at a far distance for a long time with the head posture, but after patching she is walking without any head posture. This is a head posture with the head tilt, and after the patching you can see the hypertropia has become manifest. It was not there when he had head posture. And non-ocular torticollis, as you see in this girl, we patched the eye. After some time there was no difference at all, and she had a tight sternomastoid. After physiotherapy she improved. And goniometry with a very simple goniometer can be done to see whether there is chin up or down. Chin up or down measurement can be done, head tilt can be measured, and also face turn can be measured against a straight line compared to the 2 limbs of the goniometer. And some of the common situations are essential esotropia, where face turn occurs in a cross-fixating essential esotropia, which is not very uncommon. And in this child, you can see there is a face turn to right when he is fixing with the right eye, which is cross-fixating, and face turn to the left when he is fixing with the left eye, the cross-fixing eye. So early surgery between 8 to 18 months is the general consensus now in essential esotropia. And here there is a marked chin-up posture in this ptotic child, and after correction it is completely. So early surgery is warranted in these cases, we cannot wait. Some of the cases, ptosis, if it is not severe and no head posture, you can wait. But this after surgery of one eye, she still has a chin up and face turn. So after both eyes, she is okay. And when there is a mechanical ptosis, as you see here is in capillary hemangioma, you can do patching so that binocularity will be maintained and see whether they have a large astigmatism. It has to be corrected if it is severe. And patching has to be done till at least she starts looking with both eyes. You can treat with timolol maleate, either topical or oral. So coming to paralytic strabismus, congenital superior oblique palsy is the single most common cause for ocular torticollis, which I did not believe during the initial stages of my post-graduation. But now I see and I agree totally that it is the commonest paralytic strabismus which we strabismologists come across. There is a head tilt to the opposite side, that is there is left hypertropia maximum in right gaze and Welchowski positive, and a large extorsion is there of the fundus. Still they have binocularity, that's why they keep the head tilted. And there is a facial asymmetry. If you see, there is a hypoplasia of right side of the face and fullness of left side, which has disappeared after surgery after 1 year. So this is the importance of doing surgery early. So we have seen 70 to 80% of our cases with facial asymmetry and head posture, abnormal head posture. So because this is very common, we'll just see that he doesn't show any hypertrophy unless the head posture is corrected. Now that the head posture is corrected, he shows left hypertropia, and which is maximum in right gaze, and also Welchowski positive. You can see left hypertropia, maximum in left head tilt. And in these cases, you can also measure the asymmetry between both sides, canthus of lateral canthus and angle of the mouth distance can be measured on either side, and see whether they improve. In the very young, it improves after surgery. And this child also, see the very next day the she has not developed much of a facial asymmetry. The very next day after surgery she improves after inferior oblique anterior transposition when there is a large hypertropia and unilateral superior oblique palsy. This is plagiocephaly produces a somewhat similar picture with an underaction of superior oblique due to desagittalization, meaning a flattening of the left forehead produces underaction of superior oblique, which also has to be dealt with even in that age. So acquired superior oblique palsy doesn't produce much of a hypertropia, but torsional diplopia, which is very troublesome, and double Maddox rod shows large torsion. And sometimes there may be a bilateral superior oblique palsy which has to be ruled out, especially when there is a chin down posture without marked head tilt and a V pattern esotropia. So in these cases, we do a Harrod-Ito procedure, which is strengthening of the torsional anterior fibers of the superior oblique, which completely relieves the patient of the torsional diplopia. Even though we don't see the hypertropia or anything, functionally they are okay after the surgery. Now coming to sixth nerve palsy, congenital sixth nerve palsy is not so common, and any abduction deficit in a child has to be considered as a DRS. But this child had a marked head posture which he refused to correct, and marked face turn, and after repeated examination and neurological evaluation, we diagnosed it as lateral rectus palsy, and after surgery you can see his head posture completely was corrected. And this is a third nerve palsy with a right face turn, left adduction deficit. He had surgery in childhood. Later, we had to do a periosteal fixation. You can observe the saccadic movements, that the left eye is moving slow in this left partial third nerve palsy. And first generation test can be assessed to assess and plan surgery, which muscle to be tackled, whether there is any benefit from medial rectus surgery. This is a monocular elevation deficit. MED usually produces a chin up posture because the eye doesn't go up. There is a chin up posture. It may be paralytic or some restrictive component may be there. So depending upon that, we have to decide surgery. And Knapp's procedure or Nishida's procedure is the recent consensus to do transposition. Restrictive strabismus, as we all know, DRS is the commonest, and surgery is indicated only if there is a marked phase turn. This child had a DRS left abduction deficit with an ESO-DRS as we call, and marked phase turn was completely relieved after medial rectus recession. And this boy has a marked face turn to right, which was correct, which forcible primary posture showed exo-DRS, and the eye almost disappears when he tries to look to the right. So after surgery, okay. So Brown syndrome is another situation where we can miss in childhood, and from a far distance you can see that this face turn to opposite side and fundus intorsion may be there. And this is after surgery, the elevation in adduction is better. Blowout fracture also shows a picture similar. And CFEOM has to be corrected in stages. Marked head posture is there, chin up posture. I think time is going fast, so I will just, some of the pattern strabismus were chin up posture with V pattern exotropia. When looking up it is exo, when looking down it is almost straight. And the commonest cause is inferior oblique overaction, which has to be corrected with the recession. And this young teacher had chin up posture because of A pattern esotropia, which was corrected with a small mini tenotomy. And nystagmus is coming up. Dr. Muralidhar is going to talk on nystagmus, so I don't want to, but you can see there is marked jerk nystagmus when he is looking to the right, so he is keeping his head turned to the left, to the right to prevent this nystagmus. And this was a periodic alternate nystagmus. Unless you look for it for at least 4 minutes, you will miss it. And you will say there is right face turn or left face turn. It keeps alternating within few minutes. So this is a term coined by Greenberg, ocular plagiocephaly. All these young ladies have been operated much later in life, and the facial asymmetry still remains. And this facial asymmetry, the deviation of tip of the nose towards one side, head tilt, hemifacial hypoplasia, asymmetry of the nostrils, all these are called ocular plagiocephaly due to face turn. And sometimes there is a late decompensation and diplopia. This patient was posted for surgery for diplopia, and later we noticed that there is a deviation of the nose and that it is a decompensated congenital superior oblique palsy. Sometimes it is too large in the late stages and we have to do more than one surgery. Thank you so much.
Thank you, Dr. Laila, for the nice presentation. Dr. Laila is very much experienced in this field, so if there are any questions that can be discussed at the end, depending